broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. That was Karen Carpenter, one of the very, very most unbelievably beautiful singers of all time. And I'm Dr. Minarsik, and today is Thursday, and it's 9 a.m. here in Chicago. At first I had CDT, and I forget that we are off of daylight time, so this is Central Standard Time now. This is our 14th webinar of the year. And up until now, we've given all of our webinars on general pathology topics, but there's still a couple left. But this is about time we could get into what we call systemic pathology, where we'll talk about diseases of different body systems. And we could start anywhere. Sometimes we start with heart and blood vessels and then lung. But we're going to start with blood cells today. It's a very fun topic. And I think most pathologists would love to talk about it because they spend so much time in it. And it's basically going to be 8 systems that we'll talk about. We're going to start today with the first one. Then we finish these, we'll probably finish up a little bit on the rest of the general pathology topics, which will be environmental disease, pediatric disease, and infectious diseases. Okay, are we ready to start? I think so. I made all the announcements I wanted to say. Maybe if you were at the last webinar, you might remember I had hair. I don't have hair now. Me and my brother decided to go bald because we have a sister that is on chemotherapy. So this is our way of showing solidarity. We tried to talk a couple sisters into doing it, but we'll still see if they're going to be doing that. It's harder to get a girl to cut off all their hair than a boy, okay? At least now when I wake up, that's one less thing I have to do is comb my hair. Okay, let's drop down with the bald guy and open up with the PowerPoints again. And we will be talking about basically today red blood cells. The whole hematology discussion will be on RBC, or red blood cells. Then we'll talk about platelets. Then we'll talk about coagulation. Then we'll talk about white blood cells. Then we'll talk about those white blood cells that we call lymphocytes and the lymphoid organs and diseases of those as well. And then I'll wind up being about 181 PowerPoints, which would probably take about 6 hours to do. So we're going to do part 1 of 3 parts today, about a third of it. We'll be talking basically about anemias and platelet disorders and get into parts of coagulation disorders a little bit. So that's our agenda for today. And specifically, at first we'll do a little bit of review of the anatomy, histology, and physiology of red cells. Then we'll be talking about the big topic, the main topic of red cells is when you don't have enough of red cell or oxygen carrying capacity, anemias. We'll be dividing them into 2 or 3 different types. And I have to say something here, every year the medical students are asked name the 2 kinds of anemias, and they go, microcytic and macrocytic. From a functional point of view, there's 2 kinds of anemias. The ones in which your red blood cells are destroyed at an increased rate, and the ones where they are not being made in enough numbers. Then we'll talk about the opposite of anemia, rather than not enough blood cells. We'll talk about too many blood cells, polycythemias. And then I don't think we'll be talking about all the coagulopathies today, but at least the ones that involve platelets, okay? So this is our agenda for today. And this is what your experience may have been up until now with hematology. Maybe you've seen this a million times. Maybe when you get into practice, you'll have a little microscope in your office and you'll be looking quickly at blood cells. And on this particular side, we only have red cells and a couple of little platelets, which you might recognize instantly. Notice that the red cells are all about the same size. And also notice, because they are biconcave discs, like you see here and here, that there is a central pallor due to the fact that the middle of the cell is not as thick as the outsides. And, we learned a lot of things as residents about hematology, but the one thing I learned recently was not from a pathologist, it was from an internist, Dr. Pabon. He reminded me that the pallor, the central pallor of an erythrocyte or red blood cell, if you have it nice and flat, should be at least 1/3 the diameter of the whole cell. And the diameter of the whole cell, if you remember, kind of a gold standard if they're normal in size, is about 7.4 microns, which is a little bit less than the nucleus of a small lymphocyte. And speaking of some of the other cells, which we did not include, here is a poly, a stab. We talked about them in great detail in previous chapters. In this one, it looks like it might even have a hypersegmentation rather than its average of 3 or 4 lobes per nucleus. This looks like it could very easily be a precursor to the seg or the poly, and this is what you might call a band. Some people call them stabs. Here's another one. And looks like something in between. It doesn't quite look like it has fully developed lobes yet, but it looks like it's somewhere halfway between a band or a stab, which is the same name, and a mature, what we might call segmented, or what the hematology text will call a seg. Okay, here's your lymphocytes, which we talked about. We talked about immune diseases. Do you remember I told you that the rather spherical nucleus is a little bit larger than a red blood cell? So if the red blood cells are 7.4, they say the 10 micron diameter of the small lymphocyte is another gold standard. It's even more reliable than the 7.4 micron. When you're looking at things under the microscope and you don't have any way to calibrate it with real size. A couple more lymphocytes. Notice that in every case, there's just a small lip or a very small rim of cytoplasm, and that's why when you see lymphocytes in tissue, that tissue looks extremely blue because the cells in there are 90+% nucleus. Whereas when you look at polys or segs or bands, it's probably only about 50%. So overall, the tissue or the field looks a lot lighter because there's more red relative to the blue, or more eosin relative to the hematoxylin. What are these things? Oh my God, are these lymphocytes that probably got some kind of granules? Well, these are actually basophils, and what you should understand is that the granules of the basophils are so dark that they often obscure the rather lobulated character of the nucleus. So you might say that these could be lymphocytes at first glance, but they're really, with all these granules, basophils, okay? The dark basophilic granules containing pretty much the same things mast cells do, like histamine, heparin, maybe some serotonin, I don't know. These are monocytes, and we refer to them as monos and the peripheral smear, but when they go into tissue, they're called macrophages. Sometimes the macrophages are called histiocytes, which is the same name, but when they're in the blood vessel circulating around with the other cells in their proper proportion, they're called monocytes. And even though it says mono, you might think this is not really a totally spherical or mononuclear. It looks a little bit like a stab. It's a little bit cerebrated or convoluted. Well, even though we call it a monocyte, the nucleus is not perfectly spherical like it is with a lymphocyte. And that's one way of differentiating it. Here's a couple of red blood cells just hanging out with each other. And I'm not sure what this is. This is probably a neutrophil. But look at how red and thick the granules are of an eosinophil. The nucleus of an eosinophil is not fully lobulated like a neutrophil. It's more like a stab or a band. It's not like a seg. But the red granules are always redder than the granules that you see in the neutrophils, no matter what kind of stain is done or whether it's done properly or improperly. Here's a couple more cells, but now we're no longer in the peripheral smear. These cells might look like lymphocytes at first, but they are nucleated red cells. Okay, you don't generally see them too much in the peripheral smear, except under pathologic conditions. And here they are in the marrow. And as they mature, the nucleus gets darker, and the nucleus gets smaller, and the cytoplasm basically goes from blue to red. That would be a maturation pattern. Now, I am not a big nut on memorizing things, but you're going to be looking at CBCs or so often with normals already printed on them. You may never memorize these either, but These are the classical normal ranges or reference ranges for red blood cells. Notice the hemoglobin itself is measured in grams per deciliter, and it's a little bit more for men than it is for women. Let's say 13 to 17 for men and a little bit less for women. The hematocrit is like around, let's say, or in other words, the percentage of the blood that is occupied by the packed red cells is also, therefore, a little bit more for men than is for women. Now, here's a little trick I want to tell you, and take a look at what I wrote there on the bottom. Even though the hematocrit is a percentage, and the hemoglobin is a unit of grams per DL, as a quick reference, as a general rule, okay, it's not perfectly 100% true, the hematocrit is usually 3 times what the hemoglobin is, okay? And then you can have an actual red count in terms of how many cells, how many millions of cells per microliter, or in a pair. For men, it's obviously a little bit more than women as well. The reticulite count should be only about 1%, maybe 2%. And this is the cells that are the very, very newly released red cells from which the nucleus has been extruded from going from the marrow to the peripheral smear. They actually can measure the volume of the erythrocyte in terms of micrometers, okay? And they can express that as an average. So the MCV is basically a measure of the size of the cell, and that should be 80 to 100, let's say, okay? The MCH is a measure of the concentration of hemoglobin. So in other words, the higher the MCH, the pinker the cell might look like on your office peripheral smear, perhaps stained with the right stain, WRIGHT. And then we have something called the mean corpuscular hemoglobin concentration. Okay, and I'm sorry, I made a little verbal typo. The concentration of hemoglobin should be the amount of pinkness that you see in it. So the higher the concentration, the pinker it is. I said that for the MCV, or the mean corpuscular hemoglobin, which is actually measured in picograms. How do you like that? If you think a gram is small, and a milligram and a microgram and a nanogram is small, a picogram is 1,000th of a nanogram. And here's an important number too. Take a look at this number. It's around 14, 13, 15. It's called the RBC distribution width. This is a measure of the variation of the sizes. So if you have a normal person who has all the red cells are about the same size, it's going to be a fairly nice normal, what you would say in statistics, a coefficient of variation. It'd be around 11, 12, 13. But let's say some cells are really big, some cells are really small, then this number is going to be higher because it varies more. You might remember from statistics, it's basically related to the standard deviation. Here's a nice picture of what you might see if you were looking at a bone marrow now. Notice it's about half fat. Even though it's called red marrow, it's still about half fat in the adult axial skeleton. And then here's the same cells, which you can see much better. You could see the characteristics of the granules, the nucleus. You could identify the cells much better on this stain of the smear of the marrow, which is usually some type of modification of a Giemsa, Giemsa stain. Remember we talked about the Giemsa stain? We talked about chromosome banding, okay? This is what it looks like on regular hematoxylin and eosin, slicing it like a tissue, and these are the cells that are smeared. So these are both, in a way, kind of necessary, because in this picture you get a true idea of the cellularity of the marrow, okay? But you can't always differentiate the cells too much, except the red cells are precursors or probably have a smaller, darker nucleus, and the ones with the larger, not so dark, are probably in the myeloid series. But up here you could identify the cells perfectly. Okay, so when your patients get bone marrow exams or you write a consult for a hematologist to see your patient, he'll do a bone marrow exam, or a pathologist might do one, which I've done a million, and they might even drill out a little core of bone from the iliac crest or suck out some marrow from the sternum, depending on what they like to do. So where is marrow? Don't forget, marrow is not exactly the same thing as hematopoietic marrow. For example, in an adult, somebody that's bigger than a teenager, okay, your marrow is inside of all your bones, but the hematopoietic marrow is in the bones of your central or axial skeleton. The marrow in your extremities, your appendicular skeleton, is what we call yellow marrow. And yellow marrow, which is yellow, doesn't contain any real hematopoietic cells. So remember that. Now, in the embryo, there's a lot of hematopoietic marrow early on in the yolk sac, in the very early stages of the embryo. And then as the baby reaches term, a lot of that stuff, hematopoietic marrow or hematopoiesis, goes to the liver and spleen. And often, even a normal newborn baby might still have a little bit of marrow in that liver and spleen. In an adult, you should not have hematopoietic marrow in the liver and spleen. If you do, then it's called extramedullary hematopoiesis. In other words, the productions of red cells in places other than the bone, okay? So, in all practicality, when you're in practice and you're practicing on adults and you want to examine, evaluate, or have the hematologist or the hemonc evaluate the marrow, they're probably going to be doing some biopsy or smear or both of the central or axial skeleton. Iliac crest, posterior iliac crest is a famous, great place. And also the sternum, some people still do sternal biopsies or sternal aspirations. Now, this is probably going to be possibly one of the most important slides we see all day, because it's what I call my airline checklist. When you get into an airplane, maybe it's your own little airplane or it's a commercial jetliner, the pilot has to check about 10 different things to make sure that plane is going to take off and land without crashing, okay? So, adult hematopoietic marrow, or red marrow, should still be about 50% fat. Adult appendicular or yellow marrow that has no hematopoiesis is 100% fat. But even in the places in an adult where we look red and they're producing red cells, it still should be about 50% fat. That's why when we looked at this normal marrow here, you're of course looking at the cells, but look, there's probably just as much cross-sectional area of fat, which is now a washed out space as well. Now, when you look at a marrow, like we sit here, you say, well, that cell is really big. And look there's kind of a big cell too. So you should see whether you smear the marrow or whether you cut it, like a tissue. You should still see megakaryocytes almost in every high power field. Not oil field, but high power field. So we're talking about at least a couple per high power field. Now, the ratio of myeloid cells with granules to erythroid cells should be 3-to-1. There should be 3 times as many myeloid precursors as there are erythroid precursors. And I know what you're saying. You're saying you're full of baloney because, there's 1,000 times more red cells in your blood rather than white cells. So why should there be 3 times as many white cells rather than red cells in the marrow. And of course, that refers to lifespan. The average granulocyte or myeloid cell only lasts for a couple days, whereas the red cells, as you will see coming up, they live for over 100 days. 120 days is the average lifespan of a red cell. Okay, when you look at the maturation of the myeloid cells, going from myeloblasts all the way down to mature granulocytes, at least a third of those should be bands or more. That means you're looking at the spectrum and you're saying it's maturing in a way. If they were all blasts, myeloblasts or promyeloblasts, you would be suspecting perhaps a leukemia or something that is arresting their development. Now remember, with the erythroids, however, the nucleus gets smaller, the nucleus gets darker, and the cytoplasm goes from blue to gray to red. That's the maturation pattern overall. Now, you know that they have to be lymphocytes and plasma cells also. It's generally a small percentage, let's just say a couple percent, but if there is some type of reactive or something causing some inflammatory response in the marrow, it could be 10% or more. But if you see more than 20% plasma cells, even if they look perfectly normal, you're probably dealing with a malignancy of plasma cells. Same thing with lymphs. If you see a bone marrow that is, largely, mostly lymphs, you're probably dealing with some lymphoma that has involved the bone marrow or even started in the bone marrow, okay? Hemosiderin, the iron, which is now being recycled in various forms, is stored as hemosiderin, and a large portion of that, if not most of it, is stored in the macrophages of your bone marrow. So you should have them present, okay? Now let me give you a little tip. If you look carefully and you do an iron stain and there's no hemosiderin macrophages, you're probably dealing with the iron deficiency anemia because that patient has basically depleted his storage iron. Now let's talk about the foreign cells, Should you ever see a gland in the bone marrow? No. If you do, it's probably metastatic disease. Should you ever see multinucleated histiocytes, perhaps, like from granulomas? No, that would be foreign cell as well. So the only cells that you should see in a hematopoietic marrow are marrow cells, which produce red and white blood cells and platelets, of course, that you see in the peripheral smear. This is an overall quick diagram, and you should know that both the granulocytes, whether they're red granules, blue granules, or neutrophilic granules, come from a general precursor cell, and the ultimate precursor cell also gives rise to the platelets, and of course the megakaryocytes before the platelets, and also gives rise to the red cells. So one cell, this one cell here, gives rise to just about everything except lymphocytes. The lymphocyte maturation, whether it's in the thymus or the bone marrow, the B cells are generally regarded as coming from the bone marrow, okay? Even though B stands for bursa, the B cells generally come from the bone marrow as well. And ultimately, both the lymphoid and myeloid maturation comes from a single pluripotential stem cell. Okay, these are generally referred to as the stem cells in the marrow, which are used also in treatment for various diseases. This is the same exact diagram. But remember, I think it's good to remember that all the cells ultimately come from a myeloid stem cell, which differentiates into the normoblast or rubroblast line, as well as the granulocyte line, whether they are basophilic granules, eosinophilic granules, or regular neutrophilic granules. And that includes the monocytes, okay? And that also includes these giant cells which stick out very, very nicely in the bone marrow exam, whether they're a smear, which ultimately fragment and become anucleated platelets. So there you go. So when they talk about bone marrow maturation or bone marrow cells, they often use the word trilinear for myeloids, platelets, and erythrocytes. Okay? Or we'll say red for the erythrocytes, whites for all the white blood cells to include the lymphs, and then the platelets, which actually are kind of blue. So you could say red, white, and blue when you talk about the trilinear maturation. Okay, now we're going to get into the actual diseases. Okay, and you would think that when we talk about diseases of red cells now, which we're starting out with, that without a doubt, the number one disease, inadequate red cells or inadequate oxygen carrying capacity, are called anemias. And here's the best definition. Most people think anemias are just low blood, not enough red cells. Well, that's what it usually is. But remember, you could have a normal number of red cells, but if the red cells cannot carry, trap, and release oxygen properly, they're functionally defective, even though they might be normal in numbers, that would still present as an anemia. Okay? Now, of course, you could lose blood by bleeding, whether it's acutely or chronically, okay? But please remember this, and this is why I have it in real big letters, and it's a big source of confusion all the time. There's only two kinds of anemias, other than blood loss, okay? There's one in which your red blood cells die before their time, the so-called hemolytic anemia. If I told you that the normal lifespan of a red cell was 120 days, hemolytic anemia would be a disease which results in those being destroyed way before their normal lifespan, sometimes massively before. Another thing would be decreased production. So from a functional point of view and a classification point of view, we're going to be talking about two types of anemias today. The anemias of increased destruction, which we'll deal with first, and the anemias of decreased production, which we'll deal with second. And there's a good number of both, but remember, the functional definition is the same. If you're anemic, either your red cells are being destroyed too fast or they're not being produced in proper numbers. How do you like that? Clinically, anemic patients don't have much energy. Why? Because they don't have much blood. They may have a pallor. Okay, you may look at their conjunctiva or their palms as a good place, and it looks whiter than usual. When I had a follow-up visit from my COVID episode last year, a nice old-fashioned physician assistant looked at my palm and she says, "You may be anemic." I love that because she wasn't rattling off numbers, like MCVs and stuff like that. She says, "You might be anemic." She's just from looking at the palm, okay? They're weak. They don't have as much energy. They could be short of breath or breathing a little bit heavy. Why? Because in the process of needing more oxygen, they breathe more, okay? Same thing with palpitations. In the process of needing more oxygen and more blood, the heart goes faster and stronger, we'll say palpitations. Also, with a prolonged significant anemia, the heart may ultimately fail. And why is that? Well, when we talked about different types of atrophy, very early on in this course, we mentioned the concept of an exhaustion atrophy. And this is probably more true with the heart than any other organ. But when your heart has to work overtime and extendedly to deliver more blood because your patient's anemic, ultimately that muscle will fail. So that's called high output, because at first that cardiac output has to be increased, but ultimately it fails, and you can have what they call a high output heart failure which is different from the general heart failure of most primary heart or cardiac muscle disease. Okay, let's talk about the easy one. You can lose blood from trauma. Okay, most patients commonly that have chronic blood loss will say small amounts of long-term gastrointestinal loss, which they're not aware of, okay? Or women with menorrhagia, that would result in a chronic blood loss and a chronic anemia. Now, even though we said the word anemia in general, in that case, they are losing blood. And when you lose blood, you lose iron. And even though you have some iron in your diet, the iron in your body can only be lost if you bleed because it's recycled, okay? So chronic blood loss, probably clinically the most common type of anemia. Old guy comes in with GI complaints, okay? Maybe you see some blood or maybe he saw some blood. There's a good chance that this has been going on. It's probably chronic blood loss. He may be iron deficient. Same thing with the woman, except in a younger woman, the most common cause might be excessive menstruation. But once she is in the menopause and beyond group, then in a woman, the most likely cause for chronic blood loss anemia, or we'll say chronic iron deficiency anemia, is gastrointestinal also. Okay, so there's the number one classification of the anemias, the increased destruction, also called the hemolytic anemias. They could be inherited as a genetic disorder, okay, or they could be acquired. So we're going to say a little bit about each one of these things over here, okay? And then after we talk about these guys a little bit, we're going to talk about impaired production. Well, what happens if you don't have enough iron? That's impaired production. What happens if you don't have that important vitamin B12? That's impaired production. Okay, what happens if you have a defective hemoglobin production in your alpha or beta chains? That's impaired production. That's the second type of anemia. Let's do this again. This is very important. I don't want you to forget it. There's two kinds of anemia. Number one, hemolytic or increased destruction. And number two, impaired production. Okay. Think of it as red cells have to be made at a good rate, and if that's impaired with, that's impaired production. And then they have to live long enough to their 120 days, but if there's a disease which destroys them because of some membrane problem or enzyme problem or drug problem, then that's what would be called a hemolytic anemia. So, those are your two kinds of anemias. Sometimes also when they classify anemias, they'll say it's a microcytic anemia. Well, that means that the red cells are smaller than they should be. That means the MCV, or the mean cell volume, is probably also low. But there's also a macrocytic anemia, where the red cells are bigger than they should be, perhaps more than 100 or 96, I think was the upper limit. And that would also be an increase in your MCV. And of course, a small cell probably might have less hemoglobin, so the mean corpuscular hemoglobin might be down. Okay, a red blood cell that looks pale might be pale because the hemoglobin concentration is low. So your mean corpuscular hemoglobin concentration could be low, or should be low, is low in a hypochromic anemia. Now, is there such a thing as a hyperchromic where your MCHC is high? Yeah, there's probably a few examples of those. Now, many anemias, however, might have an increased in your RDW, your red cell distribution width. And what does that mean? It means there's a lot of variation in the size of the cells. Some are big, some are small, some of the widths are small, some of the widths are high. So you would also use the term anisocytosis simply because the cells are not iso, they're not evenly the same size, but there's a lot of variation, which means if you counted them in the machine, the standard deviation would be big, and if you compare the standard deviation to the mean, that's called the coefficient of variation, and the RDW is basically a coefficient of variation, if you remember that from your statistics. Okay, hemolytic anemias is where we're going to start. We said the normal lifespan was 120 days. Okay, if you are destroying your red cells quicker than they should, there are normal physiologic mechanisms to increase your EPO. Remember, erythropoietin, it's made in the kidney. And normally, when your marrow is being hemolyzed, the EPO is high as a normal physiologic response. But as the red cells break down, the hemoglobin breaks down, okay? And if you remember, some of the types of byproducts of hemoglobin are so-called bilirubin type compounds like biliverdin, for example. And then ultimately, the final breakdown product is iron, now inside of hemosiderin. Okay, and also when your blood breaks down, the hemoglobin is picked up by a protein called haptoglobin. So when your hemoglobin breaks down, you have a haptoglobin hemoglobin complex. And therefore, the more haptoglobin that gets connected to your released hemoglobin is decreased. So decreased free haptoglobin is another lab feature or physiologic finding in generally most all of the hemolytic anemias. And I know what you're thinking. Well, if it's hemolyzing, that means it's being destroyed. Well, the blood can be destroyed while it's still in the vessels. That's called intravascular hemolysis. Or it could be destroyed where normally it's destroyed, in the spleen. Remember, the spleen basically recirculates the old red cells. So let me ask you a question. What do you think, even though if you had varying degrees of hemolysis, some is severe, they have a very low lifespan, or some of them are not so severe, the more severe a hemolytic process is, the more likely it is to actually occur before it even gets into the spleen, or what we call intravascular hemolysis. But basically, we have both types here. Okay, can I ask you another question, even though you're not really experts at bone marrow yet? Remember I told you that the ME ratio is normally 3-to-1. That means there's 3 times as many myeloids, which are these redder nuclei, compared to the erythroids, which are these darker nuclei. So if the normal ME ratio is 3-to-1, but you're seeing in the marrow perhaps 3-to-2 or 3-to-3, which is 1-to-1, the more your red cells break down from a hemolytic anemia, the more EPO is released, and the more increased production there is to make up for that increased destruction. So in a hemolytic anemia, your ME ratio is not as high as 3-to-1. It often is 3-to-2, and very, very often it's 3-to-3, or which is the same as 1-to-1. So when you see a marrow that has just as many red precursors as there are white precursors, there's probably some type of hemolysis going on. This is classically the first type of common hereditary hemolytic anemia. It's fairly common. You'll hear examples of it. Hereditary spherocytosis. Now, if your red cells look like spheres rather than biconcave discs, and they don't have that central pallor, and they're smaller than usual, okay, you know that they might be more susceptible to a short lifespan, okay? Now, in hereditary spherocytosis, the genes which code for the so-called skeleton of the red cell, the proteins ankyrin and spectrin, it's usually an autosomal dominant change, which means it's seen just as easily in adults as there is kids. If you lose your cytoskeleton to keep that red cell as a nice biconcave disc, and it loses its shape and becomes smaller, maybe forms buds, then these are what you might see on your peripheral smear as a spherocyte. Here's a spherocyte. How do you know that? Well, first of all, it's smaller than it should be, which means it has a low MCV. It doesn't have a central pallor because it's a sphere rather than a biconcave disc. Now, this guy down here looks like it's not a spherocyte. You see, it has that little central pallor, which is at least 1/3, but it's bigger than the spherocyte, and it is biconcave. The spherocyte has no central pallor. So these are kids and adults, jaundice, splenomegaly, gallstones. Why would they have jaundice? Because remember, when the hemoglobin breaks down, it goes into chemical changes that are like bilirubin or biliverdin. Why would they have splenomegaly? Because if the red cells are defective and they're being broken down at a quicker rate, the spleen not only has to work harder, but it gets bigger as well. Why would they have gallstones? Well, do you remember most of the gallstones? You don't remember because we didn't talk about this. Most gallstones are made of bilirubin, but they can also be made, most gallstones are cholesterol, but they could also be bilirubin. The green and the black stones are basically bilirubin, and the yellow stones are cholesterol. Well, if they get gallstones, they're most likely the black and green ones because they have increased bilirubin, okay? Here we go. Let's talk about another inherited hemolytic anemia called G6PD, or glucose 6-phosphate deficiency. You don't have an enzyme. Why don't you have an enzyme? Because you don't have the gene that codes for it, okay? Now, glucose 6-phosphate dehydrogenase, if you're a chemistry jock, it basically is part of what they call the pentose phosphate pathway. So G6PD, which is the enzyme here, converts glucose 6-phosphate. It dehydrogenates it into a compound called 6-phosphogluconate. Actually, there's even a bigger name for it. It's called 6-phosphogluconodelta-lactone. Okay, but anyway, think about it. When an enzyme dehydrogenates something, in other words, it takes away hydrogen, that's similar to oxygenated. So taking away 2 hydrogens chemically is analogous to giving it oxygen. So in your oxygen metabolism here, the NADPH balance is offset, and your hydrogen now gets the extra oxygen molecule with another enzyme. Make a long story short, we got a problem here now, and that problem results with the red cells being defective. It causes the hemoglobin to become a little bit denatured and clumped. You see those little green things or dark things inside the red cells? Those are called Heinz bodies. And even though Heinz bodies are seen in other diseases, the Heinz body or denatured hemoglobin is very, very common and classical finding with G6PD deficiency. Also, the cell membranes can be defective and they could have little chunks in them. The hematology text might call these things bite cells because it looks like somebody took a bite out of it, okay? So you know that when you got cells that are fragmenting like that, it's a hemolytic anemia. Okay, so G6PD is a hemolytic anemia. It's X-linked. It's X-linked. We could say recessive, but let's just say it's only in men. It follows the X-linked pedigree. It can also be triggered off by certain drugs and foods. Fava beans. I don't know if you've ever seen or ate a fava bean, but this is what they look like. They look like they're pretty big lima beans there. Anti-malarial drugs, certain infections. These can also trigger off the genetic disease, and even though these are things you're exposed to or acquired, it still would be in a person who has the X-linked defect, which in the gene that codes for G6PD. Okay? You can see the Heinz bodies, which we already saw here. If you do a special kind of a stain, that would kind of cinch the diagnosis. I guess you could do genetic studies as well. And because it's a hemolytic anemia, the hemoglobin breaks down, and you have increased free hemoglobin in the blood. You also have increased hemoglobin in the urine. And bingo, because the red cells are being destroyed at an increased rate and not living to their normal 120 days, they're anemic. Okay, this is a hemolytic anemia. This is the mother of all genetic hemolytic diseases. It's called sickle cell disease. If you remember, hemoglobin is called hemoglobin because it has a heme portion, which is not a protein, and then has a globin or protein portion, which consists of two chains, two alpha chains and two beta chains. So globin is 2 alpha and 2 beta. If there is a single point mutation which results in the beta chain now getting a valine amino acid rather than a glue, okay, a valine is now a substitute for glutamine, or glue. We'll just call it by its common abbreviation. This is an abnormal beta chain. The beta chain results in the cells in the presence of reduced oxygen, can take various shapes, and the most common shape looks like a little sickle. Okay, now remember, even if you have just the trait, you're not going to have the disease. Okay, and as a whopping 8% of American blacks have the sickle cell trait, which means they're heterozygous. But even the homozygous people now, which have the disease, makes it autosomal recessive, present early in life, kids, remember that? They will not easily see the sickling except in reduced hemoglobin. Let's say venous blood rather than arterial blood. Okay, so if you want to see sickle cells, get somebody who's homozygous and take blood that's unoxygenated, or rather than reduced oxygenated rather than arterial blood. Sickle cell kids could be severely anemic. They could be jaundiced for the same reason. Anybody with hemolysis is jaundiced. The hemoglobin breaks down into bilirubin compounds. They have often what they call a pain crisis, and the pain crisis is often related to the abnormally shaped cells causing small infarcts, like in bone, like in spleen. Okay, now they have what they call a vaso-occlusive disease. And why is that? Because when a normal red cell passes through a capillary, it's nice and it just goes right through. It's a little flexible, but when it sickles, it often gets caught up. Now, because it's a hemolytic anemia and the cells are being destroyed quickly, you have hypersplenism and therefore splenomegaly as well, both functional and anatomic increase in the spleen. But as the tiny infarcts in the spleen progress, then the spleen can become very, very small, simply because these small infarcts are ultimately shrinking the spleen, fibrosing it. And it's not unusual to see a spleen. A spleen usually weighs about 150 grams, about as big as a kidney. But when you have a sickler, the spleen could look like the size of a lymph node or a grape. Okay, it could be 10 times. Or you might have a hard time finding it at all. They also have problems with phagocytosis, so pneumococcal pneumonias are common. Salmonella osteomyelitis is the big thing. And of course, kids, H. flu or Haemophilus influenza is the big bacterial bug. But sicklers are much, much more likely to have problems with it. So pneumonias, upper respiratory infections, lower respiratory infections. And remember, those bones are getting small infarcts as well. So that makes them more susceptible to osteomyelitis. And here, let me make a little statement. If you have a kid with salmonella, osteomyelitis, he's probably a sickler, okay? Here is a spleen in which you have a prominence of the red pulp. You can see that these sinusoids are working overtime. They're bigger, and the ratio of red pulp to white pulp is big. So that's why the whole spleen is big. But as this spleen, with time, has those tiny infarcts, these vessels get occluded, the spleen becomes more fibrotic, it shrinks, and it could even be what we call autosplenectomy, where it just may not be there at all or hardly not at all. Another common type of hemolytic anemia, also related to abnormal hemoglobin, resulting in the cells being broken down faster, is your big family of thalassemias. Okay, thalassemias is a wide variety, a generic term involving globin synthesis. Remember the protein portion in either the alpha or the beta chains. Now, if this type of hemolytic anemia is clinically severe, it is often given the name a thalassemia major. If it is minor, or perhaps not even clinically noticeable, it may be called a minor thalassemia. And of course, it has a very complex genetics, which I'll be honest with you, I still don't even really understand it. I don't think you ever will either. But you can have carriers with traits rather than genetic aberrations resulting in real human diseases. Of course, the abnormal beta or alpha chain genetic defects is going to result in various types of abnormal hemoglobin. The abnormal hemoglobin is broken down easier. The cells generally are smaller. In other words, they have a low MCV. It's a microcytic anemia or low mean corpuscular volume. And by the way, the most common type of anemia, iron deficiency anemia, is also a microcytic hypochromic anemia, just like thalassemia. So that could be confused. Because it's a hemolytic anemia, there's often a very significant or severe erythroid hyperplasia. Let me show you an interesting picture. This is a skull. And you're going to say, oh my God, is that guy, some kind of punk or something? Why does he have all these little spikes in the skull? Well, the reason why you could see a spike-like pattern is because the area between the bone is bone marrow. This is a person with a significant major thalassemia. Remember, when you have an erythroid hyperplasia, when you have a hemolytic anemia, you have an erythroid hyperplasia. And so the marrow between the bone is actually more prominent, causing these spikes. Here's another type of hemoglobinopathy, just like sickle cell was and thalassemia was. It's called hemoglobin H. And the reason why it's easy to remember what goes wrong with H is H also stands for high. So in hemoglobin H disease, you have 3 alpha chain defects. Okay, there's 3 deletions. So now you're going to have a really abnormal hemoglobin. It's primarily in Asian, where sickle cell was primarily in African, let's say. Now, the resulting hemoglobin has a much higher affinity for oxygen than regular normal hemoglobin A, okay? Now you're probably thinking, well, that's great, man. This guy can really suck in that oxygen much better now. Well, yeah, that's true, but the problem is it doesn't want to release it. You know, I used to have a dog named Sandy, and Sandy was a golden retriever. And guess what? You could throw a stick into the lake 100 times and she'd go get it, and she retrieved it. She was really good at retrieving that stick. Like hemoglobin is really good at retrieving oxygen, but she didn't release it. Okay, so it's high affinity, but it doesn't release the oxygen into the tissues, and we have an anemia. It's a hemolytic anemia. I think this might be, we're probably near the end of our hemolytic discussion. There's another type of common situation called PNH, okay? It's generally called clinical paroxysmal nocturnal hemoglobinuria. So you would think, wait a minute, if it's nocturnal, you think maybe it happens at night. If it's paroxysmal, it happens suddenly. That's the definition of a paroxysm. And if there's hemolysis now, then maybe that hemoglobin is released from the cell and goes into the urine. That's why it's called PNH. Well, the problem is, even though that's the common name for the disease, it's both paroxysmal and nocturnal only about 25% of the time. And yes, it's due to a gene defect, but it's a gene defect that is acquired mutation rather than an inherited one. And I'll just give you a quick scheme. There is a protein in red cells membranes called GPI, and it's linked to a GPI protein, and it's what they call a transmembrane protein. Okay, now in order to have this in your cell as a normal structure, the GPI has to be coded by a gene called PIGA. Are you with me? And these are both really, really long names. For example, PIGA stands for phosphatidyl inositol N-acetylglycosaminotransferase subunit. So that's why everybody calls it PIGA. If the PIGA gene codes for the GPI to produce this normal GPI membrane protein, if this is the gene, the PIGA gene is what is abnormal, mutated as an acquired mutation, rather than an inherited one, resulting clinically in paroxysmal nocturnal hemoglobinuria. Let's talk about the last type of hemolytic anemia, and it's kind of a generic situation. Think about it. If you have antibodies coating your red blood cells, it could cause your blood cells to agglutinate. It could cause your blood cells, if it fixed complements, to hemolyze. And it could cause your blood cells to agglutinate either while it's still in your body, in other words, warm, or another possibility is that they will agglutinate or hemolyze cold, outside the body. So this is a generic situation. A lot of times you have most of the immunohemolytic anemias, because you have antibodies against your own cells. Most of the time it's what they call idiopathic, but it's also present with some diseases commonly. So an antibody would be an antibody against a red cell membrane. If they agglutinate in the body, they are generally IgG antibodies. If they agglutinate after the blood is drawn and the test tube is on the lab table, That's called a cold agglutinin, and those are IgM antibodies. Now, agglutination is strictly clumping of cells, but what if those red cells are actually lysed, hemolysed? Those are called cold hemolysins, and those are IgG antibodies that probably have the ability to fix complement. Remember, just because an antibody is on the surface of a cell, that doesn't mean the cell's going to rupture. It only ruptures if it has the ability to fix complement, and some of them do and some of them don't. So, the warm agglutinins, they're called warm because they won't agglutinate at room temperature. Warm means body temperature. Most of the warm agglutinins are idiopathic, which means we don't know why, but it's often common with certain tumors like leukemia, certain drugs. Now, in a cold agglutinin, the blood is no longer in your warm body. It's in the lab. It's in a test tube. If it agglutinates, it's usually the IgM antibody that causes the agglutination. And these are common with things like HIV, mononucleosis, but the classical and most common type of pneumonia that could produce cold agglutinins is the mycoplasma pneumonia. Okay, and also with mycoplasma pneumonia, you might not only see agglutination with IgM, but hemolysis of the cell with IgG. Now, practically speaking, when you talk about cold agglutinins or cold hemolysins, you might have an internist come up to you and say, "Hey, I drew the blood on that patient and I put the test tube in the lab in the rack, and I noticed that the blood cells were all lysed. You know, the serum was pink rather than clear." Well, that's what we mean by cold hemolysins. In the lab, if you suspect a hemolytic anemia, and this is done almost routinely with almost all anemias as a general test, the lab can test to see if the patient's cells actually have surface antibodies. That's called a direct Coombs. Or if you order a indirect Coombs, and very often they're both done, they actually test the patient's serum, okay, to see if it's tested for antibodies that have the capacity to perhaps agglutinate to the cells. So that's the Coombs test. And the last type of hemolytic anemia is probably the most logical. You know, if you have a mechanical heart valve, okay, that is perhaps a steel, a hard plastic thing. Very often as the blood passes through, it can actually damage and fracture. I'm not going to say chew up, but at least fracture the cells. Now these cells being more easily fractured have a less of a lifespan and will cause a hemolysis, okay? Another pathophysiologic phenomenon is if you have abnormal blood vessels. Okay, there's a disease called thrombotic thrombocytopenic purpura, where you have small thrombi in your very small blood vessels, you know, capillaries, tiny arterioles. And in the process of your small blood vessels having small thrombi, it can actually mechanically damage the red cell as it passes through. Something very much related to TTP is hemolytic uremic syndrome, which is basically a very similar or perhaps same pathophysiologic process. Okay, I think we're done with the hemolytic anemias. Okay, and I feel like we said a lot, you know, and I normally don't give a damn about your comments. Actually, I should. But I just want to ask you one thing because I'm feeling just a little bit insecure right now. Do you feel I was going too fast or too slow or the right speed? I just need a couple people to really tell me the truth, because, you know, we really said a lot of stuff in this first hour. So in my opinion, I feel like a little tired almost because we really threw a lot of stuff at you. Hopefully you had been aware of a lot of it already. So my question is, was I too fast or too slow? Okay, well, if you're not saying anything bad, then maybe there is nothing bad. So we're going to have a kind of an easier second half after our break. We'll take another 10-minute break. It's already 5 minutes after the hour. We'll come back and finish up our discussion of red blood cell disorders, the anemias of decreased production, because up until now we've been talking about the anemias of increased destruction. So we'll drop the guy down. We'll give you another view of Chucky. Chucky is a dog that I met in Puerto Rico that actually guards the television towers on one of the highest mountains. And he's basically a killer. But he wound up being my best friend, and he wound up being my dog's best friend too. So not only was he my best friend, and he just loved it when I came by to give him treats, but I'm sure he would absolutely kill anybody that tried to mess with me, and that's why I love Chucky. Okay, let's see if we want to show you the wall again during the music break. Okay, yes, we do want to show you the wall. So see you in 10 minutes, folks. We'll give you 3 nice favorite songs. I'll let you see the doll's head, too. Here we go. See you in about 10.
Sail on a dream on a crystal clear ocean, to ride on the crest of a wild raging storm, to work in the service of life and the living, in search of the answers to questions unknown, to be part of the movement, part of the growing, part of beginning, to understand. I calypso, the places you've been to, the things that you've shown us, the stories you tell. I calypso, I sing to your spirit, the men who have served you so long and so well. Oh Lord, like the dolphin who guides you, you bring us beside you, to light up the darkness and show us the way. For though we are strangers in your silent world, to live on the land we must learn from the sea, to be true as the tide, free as a wind swell, joyful and loving in letting it be. I calypso, the places you've been to, things that you've shown us, the stories you tell. I calypso, I sing to your spirit, the men who have served you so long and so well. I calypso, the places you've been to, the things that you've shown us, the stories you tell. I calypso, I sing to passing by, they would stop and say, oh my, but that little country boy could play. Go, 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 Johnny, go, 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 Johnny, go, 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 Johnny, go, 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 Johnny, go, go, Johnny, be good. His mother told him someday you will be a man, and you will be the leader of a big old band. Many people coming from miles around to hear you play your music when the sun go down. Maybe someday your name will be in lights saying, Johnny, be good tonight. Go, 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 Johnny, go. 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 Go, Johnny, be good.
We're back for the second half, and the second half won't be as grisly, in my opinion, as the first half. Believe it or not, the anemia of decreased production is basically two or three big things like B12, iron deficiency, aplastic anemias. So this is going to be a little bit less intense than the first hour. It's probably going to be shorter too, because it's already quarter after, and I don't like to keep you too long. So let's go back. Let's get rid of the bald guy. Go back to the PowerPoints. And these are the classical and probably more common types of anemias that your patients will probably have. Megaloblastic anemias, anemias which have big precursor cells, resulting in big mature cells due to B12 deficiency, folate, other things. Iron deficiency anemias, without a doubt, probably the biggest one, so I'll make it the biggest. Anemias of chronic disease, a very big number of those. I think a good rule is if your patient has a significant chronic disease for which he's hospitalized, there's also probably a good chance he's anemic as well. The anemias in which the bone marrow is aplastic, usually because of toxic exposures, rather than genetic factors. There's only one genetic one. And usually these are not only of the red cells, but they're of everything, the platelets and the white cells too. The red cell aplasias, in which is a kind of a pure red cell aplastic anemia, and a couple other things we'll mention. So there's how we'll start out. The megaloblastic anemias. What's a megaloblast? A megaloblast is a normal blast or rubeloblast or whatever you want to call a bone marrow red precursor that is very big. That's why it's called megalo. Okay. Now, if you remember, just because we have a megaloblast, which is a big red cell precursor, it will give rise to red cells which don't have nuclei in the peripheral smear, which are also big. So in other words, they are macrocytic, in which the MCV is now greater than 94, but usually it's well into the hundreds. Okay, the reason for that is impaired DNA synthesis, usually, and the reason for that impaired DNA synthesis is some problem in the absorption or handling or deficiency of B12 and folate, as well as a few other things. Now, as a result, the bone marrow may not only be hyperplastic, and hypercellular, in other words, but these changes often occur in the white or myeloid series also. This is your megaloblastic anemias. Now, do most or all of the megaloblastic anemias Do the megaloblasts result in macrocytes? Yeah, usually they do. But are all macrocytic anemias due to megaloblasts? No, there are other things like liver disease, for example, where you could have big red cells in the peripheral smear but no megaloblasts in the marrow. So this is something that I always show to scare you, because if you wanted to memorize, you had a tremendous memory, much bigger than mine. These are the common things which Now, I'm not going to tell you to remember this. In fact, I'm not going to tell you even to read it, okay? Because a regular human being understands the physiology of vitamin B12. Can take all of these, 10 or so, or 15, whatever, and divide them into three things. If you have a problem with vitamin B12 in your diet or oral ingestion, that would be one reason for a megaloblastic anemia. If you have enough in your diet, but remember, it has to combine with intrinsic factor coming from your parietal cells in the stomach, okay? So if you have a problem with your stomach, your gastric mucosa, like gastritis, or perhaps antibodies against the stomach mucosa or antibodies against intrinsic factor as an autoimmune disease, then that would be another level for megaloblastic anemia. And remember, once your B12 combines with your intrinsic factor, it has to be absorbed in the terminal ileum. So bowel inflammatory diseases, especially diseases that often involve the terminal ileum, like Crohn's disease, for example, might also result in megaloblastic macrocytic anemias. Now, this is something important, so I want you to remember that even though we're talking about anemias, megaloblastic macrocytic anemias, due to defective DNA, due to problems with getting enough vitamin B12, it's not usually just limited to the red cells. For example, you could have big neutrophil precursors, what we would call big bands, okay, or big metamyelocytes, okay. And not only that, not only can your neutrophils, precursors, be bigger, but once they are fully developed as a segmented neutrophil, they're hypersegmented. So if the average number of lobes or segments in a neutrophil, or seg, for example, is like between 3 and 4, when you look at these under the microscope, often you'll see 5, 6, or 7, as an average. So not only are they megaloblastic macrocytic anemias, but they can have hypersegmented neutrophils. Common name for the B12 megaloblastic anemias often just has the term pernicious. And pernicious, of course, just means kind of like evil or bad. It doesn't have a specific thing. The pernicious anemias, the megaloblastic B12 anemias, they can have hypersegmented neutrophils. And not only can they be anemic, but they could be leukopenic. Now, this is the one thing I've never been able to understand. It's not a hemolytic anemia, but due to some pathophysiologic reason, which I really can't understand, they can be a little jaundiced as well. Another common finding with patients that have B12 megaloblastic anemia is problems in their dorsolateral vesicular tract of the spinal cord. So that's dorsal and that's lateral. So these little tracts are called the dorsolateral vesicular tracts of Lissauer, and they carry sensory impulses. But the one sense that they are kind of noted for is the vibratory sense. Okay? So that's why if you take a tuning fork and put it on the bone of one of these patients, they might have a hard time feeling the vibration. Achlorhydria, well, wouldn't that be a great association? Because if they don't have stomach acid from the parietal cells, they might not have intrinsic acid either, intrinsic factor either, because both stomach acid and intrinsic factor are made by the same cells. They maybe can't absorb the B12 because of problems at the stomach level, or perhaps of problems at the terminal ileal level, and therefore they have a low serum B12 test. Now there's a radioactive tracer test where you give them radioactive B12 to see how much comes out in the urine. So I don't know how often that's done, but we used to do it all the time. They flunked the Schilling test because they can't absorb the B12. They can't absorb the radioactivity in the urine either. Behaving very similar to B12 deficiency, causing the same type of picture, is folic acid or folate deficiencies. People that are big vegetarians, for example, might be defective in folate. Some of the drugs like anticonvulsants, chemotherapies, patients on hemodialysis, patients that are pregnant or have parasites, or infants. The big difference chemically between folate and B12, even though the deficiency of them may produce both a megaloblastic macrocytic anemia, is that usually people have enough stores of B12 to last for a long time. Even though it's a B vitamin, it's a water-soluble vitamin, not a fat-soluble vitamin. Even though it's a B vitamin, if you didn't have any in your diet, the stores that you have in your body can last for a long time, months or maybe a year. Whereas folate is depleted very quickly. So that's why it might be low in pregnancy, and might also be interfered with these common medicines, anticonvulsants, birth control pills, and chemo. Now for the big anemia, probably the only type of anemia you may have heard of widely is your iron deficiency anemia, the most common type. It's an anemia of impaired production because you don't have enough iron. Now, you're probably thinking, well, wait a minute. If iron is recycled in the body, how could you be iron deficient? Well, if you bleed, you lose iron. So really the only way you could lose iron is by losing blood, because iron, Fe, is recycled. Okay, but that blood loss may be very, very subtle. Most people with iron deficiency anemias don't even know they're losing blood. They don't see any red color in their stools. It may be a very slow process. It may be a polyp that's bleeding, or it might be a woman who just, realizes that she's kind of heavy with her periods and menstruating heavily. And these are like the common causes. Not only are they anemic, but the cells have a low MCV, or they're microcytic, and they look a little pale. They're hypochromic because their hemoglobin concentration is low also. Here's your iron cycle. Okay, well, where should we start? Well, let's start where you have most of your iron, in the heme of your circulating erythrocytes. Okay, well, eventually this is in a situation of balance with your iron that's stored as hemosiderin in various parts of your bodies, of which the marrow is, of course, the big place. This iron can now be in the chemical form of transferrin. And I think transferrin is a good name because there's basically another homeostatic balance between the iron here and the iron in the liver, which is another place for iron. And this transferrin then can go into the marrow precursors to form the red blood cells. So when the reds develop from normoblasts into mature red cells, they need the iron, and that's where they get it from. And don't forget, you also have iron in your diet as well. But technically, if you didn't have much iron in your diet and you never bled, technically, you wouldn't become iron deficient. There's a simple lab test that you could do called transferrin. Okay, a form of it would be ferritin. Even though they're different, they're related, because if your serum ferritin is low, your body iron is probably low. But another way to find out if your body is low on iron, is to actually do a bone marrow exam. And when you have an anemia patient and you call in a hematologist, he's probably going to do a bone marrow exam. And in patients with iron deficiency, there's practically no iron in their macrophages, in their bone marrow. So that's why the two big tests for iron deficiency, one is non-invasive, it's just a simple lab test called ferritin. If that's low, they're probably iron deficient. Or if they get a better evaluation and they're looking at the bone marrow, they may see that there's no hemosiderin in the marrow, macrophages. And even if they stain it with that stain that's supposed to make iron stand out very strongly, called the Prussian blue. Clinically, once again, when an adult man comes into your office and he's iron deficient, he's probably had GI blood loss. If a premenopausal woman comes in and she's iron deficiency, she's probably been losing blood through excessive menstrual bleeding. If she's beyond menopause, okay, she's going to be like the man. She probably has an occult GI blood loss. So I would say almost always, whenever a man or older man or woman comes into the doctor and they're iron deficient, they go immediately to the GI consult, because he's going to see if he could find out why they're losing the blood in the GI tract. Here's a classical picture of a blood film. Look, some of the cells are small, some of them are big. There's a lot of variation. So this is what you call anisocytosis. It also would be an increased RDW because of the statistical variation in the size of the cells. Okay, also notice that a lot of the cells, rather than having that pallor, only a third, the pallor is more than half. That means they're hypochromic. That means they have a low hemoglobin concentration. So you want to confirm it, do a serum ferritin, should be elevated. Should be decreased, because the iron is decreased. Or if they get a bone marrow evaluation, even if they don't suspect an iron deficiency anemia, they always do iron stains or Prussian blue stains or hemosiderin stains, and they'll see that the macrophage iron stores are low. Here's a bone marrow again, the one we saw before, and you really can't tell just from looking at a hematoxylin and eosin if the macrophages have iron. Now sometimes you might see, if you look very closely, maybe some of these cells look like they might have some granules in the cytoplasm, like there, for example. Whoops, that could be a little iron. But you don't really know, okay? You don't know how much iron. Well, if they're iron deficient, they should have 0 iron. Otherwise, you could quantitate it, from 1 to 4 or whatever. And when you stain those macrophages with this Prussian blue stain, and they have normal iron, you see all these nice blue little dots, most of which is, inside of the macrophages, but some of them are in the normoblasts as well, okay? Another common disease, and this is not a specific disease, it's a family of diseases. And I bet you that if you went into your hospital right now and you looked at the CBCs on every patient that was seriously ill, either with a liver or kidney failure, with a tumor that was, widespread, chronic immune disorders, significant chronic or acute infections, pneumonias, most likely they would be anemic also, but they would have normal iron. So that's one of the big ways to differentiate iron deficiency from an anemia of chronic disease, is that the chronic disease people, through a wide variety of reasons, are anemic, but they have normal iron. And the iron deficiency patients are anemic, but they have a low ferritin or absent storage hemosiderin in their marrow macrophages. Here's a kind of a misnomer. Here are the aplastic anemias. It's a category of anemias where there is very little growth of red cells. Remember I told you that the ratio of fat to hematopoietic cells in a bone marrow should be 50-50? Well, in aplastic anemia, it might be 90 or more percent fat. Okay, there's just not much growing in the marrow, and it's not specific usually for red cells. There is a type of aplastic anemia that is specific for red cells, however. I think it's called a Schilling's anemia, and it is fairly specific for red cells. Otherwise, the aplastic anemias, most of them, even though they're called anemias, you see decreased reds, you see decreased whites, you see decreased platelets, and they're almost always due to something that they acquired or were exposed to, like drugs and toxic chemicals. There is one type of aplastic anemia that is inherited. It is called Fanconi's anemia, and it's not acquired. So what kind of things might be causing this type of stuff? Well, first of all, take a look at this marrow. Here is the bone. Okay, you can see that, and here is the marrow spaces between the bony spicules. Well, that's more than 50% fat. To me, this looks like it's at least 90% fat. So you would call this aplastic anemia bone marrow hypoplastic. Even though it's called aplastic anemia, you would call it hypoplastic, very low in the number of marrow cells. Here are some of the common things, exposures. Remember, this is an acquired thing. The big drug, of course, chloramphenicol, which was a tremendous antibiotic many years ago when I was a kid, was found to be causing people that had no growth of red cells, white cells, or platelets. This was a big common cause. That's why hardly ever used now. A bunch of other antibiotics. The reason why you might check hemoglobins and white cells with a lot of drugs is simply because they might have been linked to aplastic anemias. Chemotherapies are not only killing tumor cells, but they could be killing the bone marrow precursor cells, the stem cells. Toxic compounds, insecticides, and in particular, here's a couple of viruses in the herpes family, like Epstein-Barr, okay, mono, and Burkitt's lymphoma, or varicella zoster, shingles and chickenpox, as well as your regular old hepatitis B virus exposure has results. So I'm not going to go into all the pathophysiology. It's complex and I probably don't understand it, but you should know that most aplastic anemias are due to exposures of viruses, industrial chemicals, chemo, and a lot of antibiotics. This is a type of anemia that I always laugh at when I talk about it, because I never saw a word in English where the P and the H and the T and the H come together with no vowels in between. This is called a myelofistic anemia. And in a myelofistic anemia, it's an anemia, but you also see that the red cells often have these little, looks like they've been kind of squeezed out, little pointed edges on them. I'm sure that the hematology texts have a certain name for them. But the myelofistic anemias are, even though other things cause them, the most common thing is when a marrow is replaced by metastatic tumor cells. That's one reason for having decreased production, is that cancer is, occupying most of your marrow. And a myelofistic anemia is generally associated most commonly with metastatic cells replacing the bone marrow. Okay, we're done. We're done with the anemias. We're done with all the anemias of increased destruction. We're done with a smaller list of anemias of impaired production. So what's the opposite of anemia? Well, if anemia is, let's say, too little cells, then polycythemia looks like it's too many cells, poly. Now, technically, if you took water out of your serum, it would be technically a hemoconcentration phenomenon, and it might look like the hemoglobin and hematocrit are are increased simply because the water, relatively speaking, is less, maybe in evaporation. But there is a reason for having an absolute increase in red cells. The true type of increase in red cells, or VERA, is a disease. It's called a myeloproliferative disease, where the bone marrow, the myelo, has proliferated to produce too many red cells. It's not necessarily a leukemia. It has a small association with acute leukemias, but not very high. But if you have a polycythemia vera, it's not because your EPO is high with these other reasons. It's because your EPO is low. So how could you have an increase in red cell production without erythropoietin causing it? That's why this is called a true type of myeloproliferative disease. It's one of the 4 types of myeloproliferative diseases that we'll be talking about. Now, to make these even more interesting, is that in polycythemia vera, not only are the reds increased without the stimulus of EPO, but also the whites are, the myeloids, and often the platelets are as well. So it's non-specific, okay? Now, in most of the polycythemias that you see, however, which are not true autonomous from EPO, polycythemias, they're because you have some physiologic reason for high EPO. So the higher your EPO, the higher your red cell production, the higher your red cell numbers, the higher your hemoglobin, the higher your hematocrit. People that live at very high altitudes where air is thin have a physiologic mechanism for increasing their EPO as a normal physiologic response. Some tumors produce erythropoietin. So wouldn't that be a reason for a polycythemia? They may not be chemically perfectly normal erythropoietin. They might have a couple amino acids difference, but they still have the same effect. Okay? If you remember some of the athletes that were banned from the Olympics, were banned because they were taking EPO to dope up their red cell count so they would have more energy. So doping. And there's even actually something I was involved with, so I'll mention that. It's called CVAC, cyclical variation in altitude conditioning. That's where people go into little pods that are about the size of a very tiny car, and they have the pressure varying, cyclical variation in the pressure. And as a result, that physiologically boosts their EPO, much in the same way people that living in high altitude with low pressure or low oxygen pressures also have a high EPO. Okay, here's P. vera. This is the true one. It's a myeloproliferative disease, but part of that marrow proliferation primarily are the red cells. However, you could see increased megakaryocytes, you could see increased whites, but not from this field. And remember I told you that marrow should be 50% fat and 50% cells? Well, this is more than 50% cells. So it's a true proliferation of the marrow. Okay? Even though it's a myeloproliferative disease, and you're asking, well, if you have a proliferation of the marrow, could it go on to leukemia? Well, yes, it can, and it does in a few cases, but not very often, okay? You know what? I think we're going to stop here. No, we're not going to stop here. I want to say, let's see. No, we're going to stop here for today. I think I threw a lot at you. I feel pretty guilty. The next webinar will talk about bleeding disorders, at first primarily platelet bleeding disorders, but then we'll talk about coagulopathies as well. and then we'll move into the white cell disorders in the next webinar. There'll be a total of 3 webinars on heme, and we've already done about a third of them. So if there's like 180, we've done almost 60. So I don't feel too guilty. So today is Thursday. That means in 5 days from now, next Tuesday, we'll do heme 2, which will start out with bleeding disorders, and then white cell disorders, and then lymphoid organ disorders for the rest of the topics on heme. Okay. I think, wow, maybe there's been some comments. Hold on. Oh, yeah, there has been a lot of comments. Thanks. I'm reading them quickly. Some people have already known that sometimes these teardrop cells that we saw with myelofistic are dacryocytes, elliptocytes. I have a thing at the end of this chapter which you could go to online, and it'll give you all the funny names of abnormal red cells that the hematology techs know well, and probably better than I do. So let's call it a day. I don't think we need to put on any more pictures, and we'll see you in about 5 days. And we'll kind of close off with our final song.
When troubles come and my heart burden be, then I am still and wait here in the silence until you come and sit a while with me. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. You raise me up to more than I can be.
Rock on, Buzzards. And I will remind you that it would be really nice if you raised somebody up today. And also, when you are more than you can be, I think you could figure out who's probably raising you up. Rock on, Buzzards.